Hi, this is Kendrick with worldmedicalschool.org. We're going to talk about acidosis. This is a topic that is not covered in real depth in most review materials, but it's an important topic and one that will be important especially in practice. So I'm going to go into just a little bit more depth than review materials usually will go, but there's definitely more to learn about it, so I'll give some other resources to go to after this. So acidosis means low pH in the tissue. It also means just the process of creating more acid. And acidemia is specifically blood pH less than 7.35. And the symptoms of this, the way that most people present, is with some kind of CNS disturbance like confusion up to coma, some kind of respiratory disturbance, usually shortness of breath, and tachycardia and GI symptoms are real prominent parts of this. So when do you order the ABG, the arterial blood gas, which is one of the most important measurements in diagnosing acidosis? Well, if you have any of these symptoms, then you might want to order it if you don't know what's causing it, or if you have reason to believe that one of the causes that we're going to talk about in a minute is part of your patient's presentation. So normal pH is around 7.4. Normal PCO2 is about 40, and normal bicarb is about 24. And we'll talk about how to use these numbers to differentiate between a respiratory and metabolic acidosis. But let's talk a little bit more about some of the terms that we use. Acidemia, again, is less than 7.35 blood pH. Gap is, or anion gap, is the difference between measured cations and measured anions. So sodium, chloride, and bicarb are the ions that we usually measure. Potassium is sometimes included in this, but most often it's just sodium for the cations. And the difference between these is going to equal the unmeasured cations and the unmeasured anions. So usually we have a greater number of unmeasured anions, and it's and the normal number is 11 for our gap. So over 11, really over 14 is where we start talking about increased anion gap. So if you have an increased gap, metabolic acidosis, and there's another thing that we can calculate called the delta-delta, or the delta ratio. And I'm not going to go into super great depth with this, so if you don't understand what I'm saying, there is a great video that you can watch that will just spend 10 minutes going over this one concept, and it's really good. So the delta ratio is the change in anion gap over the change in bicarb. So in a gap acidosis, for example, a lactic acidosis, you're adding lactic acid to the system, so the lactate is going to be another anion that is going to add to our gap, and then the hydrogen from the lactic acid is going to deplete our bicarb. So normally in a gap acidosis, the change in the gap is going to equal the change in the bicarb. So a pure gapped acidosis is going to be somewhere around 1 to 2 for your delta ratio. If you have a delta ratio that is less than 1, then that means that you have a gap acidosis, but you also have a non-gap acidosis. And if your delta-delta is greater than 2, then you have a gap acidosis plus a metabolic alkalosis. Again, if this doesn't make a lot of sense, just watch this video that I've got a link to here, and it will go into a little bit more depth and be helpful for you. So we got an acidosis. We start out by looking at our CO2 levels. So normal is 40. If it's more than 40, then we think respiratory acidosis. So we've got a pH that is less than 7.35, and then we've got a carbon dioxide that is greater than 40. So we know that we're not getting rid of enough carbon dioxide, and that is leading to our acidosis. So some of the causes would be lung disease, drugs that might depress our respiratory system, and some kind of a muscular problem that might depress our respiratory system. If your CO2 is less than 40, then we know it's a metabolic acidosis, because that means that it means it's not a respiratory acidosis, so we're not retaining carbon dioxide. So causes of metabolic acidosis. First, let's talk about the gap. So if a normal gap is 11, an increased gap might lead us to think of chronic renal failure, lactate, diabetic ketoacidosis are some of the big ones, and toxins. And a normal gap will make us think of diarrhea, glue sniffing, I don't know why that was one of the more common ones I included, or renal tubular acidosis. So again, the increased gap is we're adding something to the system like lactate, or ketoacidosis, where we're adding ketones, which also are anions. And chronic renal failure, intoxication, and massive rhabdo are all things that can lead to this. In a normal anion gap would be like diarrhea, because we're losing bicarb, pancreatic fistula, ureterosigmoidostomy, renal tubular acidosis, which we're going to talk about in a different video, intoxication, like ammonium chloride, acetazolamide, bile acid sequestrants, isopropyl alcohol, and renal failure, or glue sniffing, toluene. So you remember the mnemonic mud piles stands for methanol, uremia, DKA, propylene glycol, INH, lactic acidosis, ethylene glycol or alcohol, and salicylates. So those are the main causes of increased gap acidosis. So the treatment of acidosis, if it's respiratory, you're going to try and get them to breathe better, obviously. You need more oxygen getting into the lungs, so you treat the underlying cause. Often that includes ventilation. If it's a metabolic acidosis, we're also going to treat the underlying cause, which in the case of DKA is going to be giving insulin. Fluids and electrolytes are going to be always a part of treatment, and sodium bicarb is also potentially a part of treatment, and we won't go into detail of when you give it and when you won't, but the mainstay is going to be insulin for DKA, and then just fluids and electrolytes for any metabolic acidosis. All right, thanks to Mikael Hegström for the symptoms of acidosis picture. And if you want to be involved in this, go to worldmedicalschool.org/volunteer, or just comment on the video below and help us to make these videos better. And we'll be with you again.